So a very good morning to you all, and I'd like to welcome you to this webinar, which is being organized jointly by the African Academy of Sciences, the Africa CDC under the AU, ALERT, and the WHO Regional Office for Africa, AFRO. The topic for today is a clinical update, and it's on dexamethasone and hydroxychloroquine for the treatment of COVID-19. I'll go straight to the point, and I'd like to invite a colleague from Africa CDC to just give a welcome note over the next 1 minute. Akona.
Thanks, John. Welcome to everyone who's participated in this very important webinar. Africa CDC is really honored to be part of this collaborative effort to bring science and really powerful research such as this clinical trials closer to the member states, essentially to help them fully understand the various treatments that can support the mitigation of this pandemic. We hope countries will get the clarity on the use of dexamethasone and hydrochloroquine for severe illness, as well as the use of hydrochloroquine during this outbreak. Just to also mention that Africa CDC hosted a conference on Africa's leadership role in developing, manufacturing, and distributing of vaccines. And this is really adds to the conversation in helping to understand the current landscape and developments for clinical trials within Africa. And so I'd just like to thank all of our partners, especially ALERT, for their willingness and offering to host the webinar. Thank you, John.
No, thank you very much, Akona, and thank you very much to Africa CDC for this amazing support for the scientific collaboration, as well as the dissemination of scientific information to scientists and others across the continent and beyond. I'd like to ask a colleague from WHO AFRO to also give a 1 minute welcome note. Over to you, John.
Yeah. Thank you very much for the opportunity. On the part of the WHO AFRO, we are happy to collaborating in this joint webinar to inform member countries and pave way to understand management of COVID in terms of therapeutics. We have had quite a number of turbulent issues with therapeutics, antivirals, and what is going to work. It comes as an encouraging news for us that slowly something we are beginning to have results and positive in that line. We are hoping that as we look forward, move forward, there will be more positive information that will help us address the issue of this pandemic on the continent. The continent is in a rising phase of the disease, and we look forward to the fact that we keep on having such informative collaboration for our member countries. And on that note, I'd like to thank African Academy of Sciences, African Union, and Africa CDC, ALERT, in collaborating to bring up-to-date information to member countries to be able to determine the way forward for management. Thank you very much.
No, thank you very much, John, from the World Health Organization Regional Office for Africa. I'd like to invite Kevin Marsh from the African Academy of Sciences also for a 1 minute welcome note. Over to you,
thank you. Thank you very much, John, and good morning, colleagues. I'm speaking on behalf of Moses Alobu, my co-leader of the team at the African Academy of Sciences on COVID, and all our colleagues in the Academy. The Academy is similarly really pleased that we're able to do this jointly with Africa CDC, WHO AFRO, and ALERT. I think for us at the Academy, one of the major pluses, I think one has to look for pluses in this kind of thing, of the whole COVID situation has been the way in which we've been able to come together with organizations across Africa and work jointly on a whole range of things. The African Academy of Sciences is involved both in programmatic funding of COVID research, and many of you, I think, on this call will have been part of the exercise that we're involved in, again, with colleagues in trying to identify research priorities for Africa. So for us, it's a real pleasure to be here today with all our partners, and we're looking forward very much to the update.
Thank you very much for that, Kevin. It's a real pleasure that we can do this morning. We're going to go straight into the meat of it. My name is John Amoyesi. I'm moderating for this morning. I sit in Kumasi in Ghana at the KNUST, which is the Kwame Nkrumah University of Science and Technology, the Kumasi Center for Collaborative Research in Tropical Medicine, which leads the work package for ALERT. ALERT is the African Coalition for Epidemic Research, Response and Training, an EDCTP funded consortium which focuses on the conduct of clinical research during epidemics. This morning we have Professor Peter Horby from the University of Oxford, who's the director of ISARIC and also the PI for ALERT, and Dr. Mainga Hamaluba, who's based at the Kemmery Wellcome Trust. Peter will be giving us the updates on dexamethasone and hydroxychloroquine from the recovery trial, which received a lot of publicity in the media about a week and a half ago, precisely on June 16th, was all over the media regarding the interesting findings on dexamethasone and hydroxychloroquine. I can already see some questions rolling in. I'll just encourage you to hold your fire and wait till the presentations are over so that your question doesn't get lost in the mix. We'll do our best to accommodate all these questions. And Mainga will be speaking about clinical trials and research, clinical research in Africa and why there's a need for this, and give us some updates on what is going on and with a focus on what is happening specifically in Kenya. And so with this, I'd like to hand over to Professor Peter Horby to present to us the clinical update on dexamethasone and hydroxychloroquine for the treatment of severe COVID-19. You're welcome, Peter.
Great, thank you very much, John. It's a great pleasure to be here. It's an honor, in fact. My name's Peter Horby. I'm professor at the Centre for Tropical Medicine in Oxford. Been working on epidemic infections for almost 20 years now. Spent a lot of time in Asia and now working more in Africa with colleagues such as John and others. But COVID is a global problem, and so we need global solutions. And so we've been working a lot in the UK recently, because we have an infrastructure which allows us to do clinical trials, which we hope will be informative for everyone, not just the UK population. John, can you see my slides okay?
Not yet. I think there is a little glitch, but maybe in a couple of seconds it will show up. So maybe we could wait just for a few more seconds, but or you want to try and turn it off and on again? We could try that.
Yeah, let me turn it off and on again, because we need the slides for the presentation. Okay, can you see some slides now?
Yeah, it comes up fine like that. It's when you go onto full screen that there's a glitch. Try it again on full screen.
Yeah, there's a little bit delay when it goes to full screen.
Yeah.
So I can see full screen on my computer now. Can you see it on yours yet?
Not yet. We'll just wait for a few seconds. Otherwise, we may have to just use the non-full screen mode.
Yeah. Okay.
Right. I think it's not working. So let's just go with the non-full screen mode. What you can do is just to blow it up a bit by pulling the margin on your left, so that we have more of the actual slide showing.
Now let me do this. How's that?
Yeah,
not bad. We can do with it. Thank you.
Okay, great. So a quick update, on COVID-19 pathophysiology. I think you all well understand it now, unfortunately. But the figure at the bottom here is from a very early paper from China, which began to see a very clear clinical picture where patients were not that sick for the first week or so, and there was predominantly a viral response. And what we now know is that the viral load peaks quite early in the illness, unlike some other infections such as SARS, where the peak of viral load is in the second week of illness. It's clearly in the first few days of illness in COVID-19. But then after a week, there's kind of a splitting of the patients. Some of them, most patients start to get better, but then there's a proportion that start to get worse. And at this stage, about a week, that's when patients start to come into hospital, they have increasing difficulty breathing, and some of them progress to acute respiratory distress and require ventilation. And so what we're seeing is an early viral response and a later inflammatory response, which takes place at about a week. So it's really got these two components to it. And so what are the targets for treating such a disease? Well, there's a number. Clearly there's antivirals, which will probably work better in the earlier stage of disease. But also then anti-inflammatories, which at a later stage disease may have a benefit. There are two other classes that might also be useful. One is anticoagulants, because we have been seeing a high rate of thrombosis, so pulmonary embolism, thrombotic strokes, etc., which is unusual for viral respiratory infections and may be related to a pathophysiology in the vasculature. And so anticoagulants is one area that's also being looked at. And the final area really is the renin-angiotensin system, because the virus attaches to the angiotensin converting enzyme on the surface of the cell. And so there has been speculation that drugs in the renin-angiotensin system, like ACE inhibitors, etc., or spironolactone, may be useful. And so on this side, there's a picture of the different phases of viral replication where you could target. So here, the virus is attaching to the cell, so you could look at the renin-angiotensin system here, and then the virus is brought into the cell, and that's where you can try and reduce the effectiveness of that import of the virus into the cell. And this is where chloroquine and hydroxychloroquine probably work best, by changing the pH in the endocytosis process. And then you get replication of the virus, and you can work on some of the enzymes involved in replication. So remdesivir works here on the polymerase proteins, and lopinavir, ritonavir works on the proteases here. And so they interfere with viral replication. And then the virus is released from the cell, and again, chloroquine, hydroxychloroquine may work here. Convalescent plasma and artificial antibodies would work by binding to the outside of the virus and stopping it attaching to the cell. And then you've got drugs that would attack the inflammatory response. So corticosteroids, azithromycin, and these drugs, tocilizumab and sarilumab, these are monoclonal antibodies that target cytokines like interleukin-6 or interleukin-1, etc. So the ones I've highlighted in yellow are the ones that we're testing in recovery now. So we've got corticosteroids and azithromycin, anti-inflammatory. We have tocilizumab, which is an anti-inflammatory, chloroquine, hydroxychloroquine, cell entry, lopinavir, ritonavir, viral replication, and convalescent plasma, which again is sort of an antiviral. So they're the drugs that we've been evaluating. And this is a bit of a busy slide, but it shows the current recommendations, or the recent recommendations. This was published in May, a review of COVID-19 clinical guidance. And this table 3 shows the antiviral therapies that have been recommended. And you can see we've got chloroquine, hydroxychloroquine, remdesivir, and lopinavir, ritonavir in various countries: Italy, Russia, France, Netherlands, Spain, China, etc. So quite extensive recommendation of some antivirals, which includes interferon, lopinavir, chloroquine, hydroxychloroquine. And then table 5 shows the recommendations for steroids, which is the reverse. Most recommendation is not to use steroids. So WHO's corticosteroids contraindicated, Italy not recommended, avoid, not recommended, just for septic shock, not indicated, not recommended, etc. So the clinical guidelines have been either recommending or not recommending these interventions. So we were really focusing on drugs that are in current guidance to see if that guidance is correct or not. So I'll bring you to the recovery trial, which is a randomized trial we've been doing in the UK. It's been designed to be very simple, very large, to get definitive answers on important outcomes like mortality, rather than surrogate endpoints like viral load or inflammatory markers. And we've made it as transparent as possible. So all of the documents are available online. We've had freedom of information requests, and actually we just refer them to the website because everything's on there. All the regulatory documents are on the website. All of the information about the drugs are on the website. Guidance for specific groups like pediatric patients, chronic kidney disease, pregnant women, neonates, etc. is there. And all the collaborators' slides are there. So they're available for anyone to look at. And I'd encourage you to go there if you have any questions about the trial. We've kept it very simple. Although this is a randomized controlled trial, we are not requiring GCP training. You know, the GCP regulations say you need to be adequately trained and have the right expertise to be conducting your responsibilities within the trial, but doesn't actually require you to do GCP training. So we're not requiring that. What we are saying is that the people who are prescribing the drugs need to be, you know, medical staff, research nurses, etc., who have the appropriate training and education. All the training is online, so all the training videos are available online. And actually, what we then ask is just for the people who've done the training, they click on this confirmation of online training, and it gives us a record that those individuals have done the training. So it's very simple and doesn't involve us doing on-site training, which obviously is a difficult thing to do when there's lockdown, etc. The consent and information sheets are simple. We have a two-page information sheet, which is here, and we have a 2-page consent form. So although we're testing 6 drugs, we've still managed to keep the information sheets and consents as simple as possible. And we also have translations of those. Randomization is online. It's very simple. It only requires the essential data to confirm eligibility, establish if the patients are suitable for particular drugs, and whether the drug is available. So if the drug is not available at your site, then you tick that, and the patient is randomized between the available drugs, not the unavailable drugs. And it takes a record of the randomizer. And so patients are then assigned between suitable and available treatment. So the patient has to be suitable for the drug, there's no contraindications, and the drug has to be available. And once those criteria have been ticked, then the patients are randomized between what's available and suitable. So this was the design when we started. We had the control arm, no additional treatment, lopinavir, ritonavir, Kaletra, dexamethasone, hydroxychloroquine, and azithromycin. Originally, it was only adults, but we changed that. It's now open to any age, including pregnant women. You have to be admitted to hospital, and you have to have suspected SARS-CoV-2 infection. About 90% of patients have SARS-CoV-2 confirmed, laboratory confirmed, but it's not an absolute requirement, because when we started, access to timely results was difficult. It was often taking 72 hours to get results back or more, and we didn't want to delay enrollment. And then the outcomes are very simple. Primary outcome is just alive or dead on day 28. And the secondary outcomes are also fairly straightforward. Duration of hospitalization, need for mechanical ventilation, need for renal replacement therapy. The trial has introduced new drugs. So we've now introduced the second arm of tocilizumab, which is an interleukin-6 antagonist. And so if patients progress, they get an inflammatory syndrome with raised CRP and hypoxia, then they're eligible for a second randomization on top of the first randomization to tocilizumab or no additional treatment. And then very recently, we've introduced a factorial design. It starts to look complex, but after the first randomization, you are then randomized to convalescent plasma or not. So you could have standard of care plus convalescent plasma or not, etc., on top of all these things, and then access to a second randomization. So we now have 6 drugs. We did have 6 drugs. So implementation, we did it pretty early. This is the an early outbreak curve for the COVID outbreak, starting at the end of December. These were 2 trials we were involved in China, lopinavir, ritonavir, remdesivir, which were completed but were too small to really give a definitive answer. And this is when we enrolled the first recovery patient. And this is the UK epidemic, and you can see that we managed to start the UK trial early enough in the outbreak. And I think that's essential. If you're going to do these clinical studies, you really have to accelerate them and get them started early. You really mustn't fuss about taking a long time with approvals and complex designs and complex biological sampling, because you'll miss the outbreak, and you'll get no results. So this is our first 100 days. So this is the main randomization here, and you can see we're up to almost 12,000 patients now. So a very big trial. This is the curve for tocilizumab. So we now have almost 800 patients in that second level randomization for patients with inflammatory syndrome. And we have about 125 patients now on convalescent plasma, which started much later. This shows the distribution of the hospitals in the UK. So because we have a National Health Service, it's across most of the acute hospitals in the United Kingdom, so 175 hospitals. And the size of the circles is the size of recruitment. This is the recruitment curve. You can see there's a big weekend effect when the research nurses are not around, the research doesn't get done. But at the peak, we were randomizing more than 400 patients per day. We now have a plateau and a decline, and we're now randomizing during the week, about 30 to 40 patients per day. The age of participants is open to all ages. So our youngest patient is less than a year, so is a few months old, and our oldest patient is 102. So it's a very big, well, you know, it's as big as you can get pretty much. But the peak is in the older adults, sort of the 50s plus age group. We've kept it simple. So this shows you the time to randomization from when you open the screen to when randomization is complete. The average is about 7 minutes. So we've really tried to keep this low burden to the staff, because they're very overwhelmed, and they have many other duties to do. So they don't want to be spending a long time on the trial. So we've kept it very simple. So now to the interesting bit, the preliminary results. So I'm going to talk about hydroxychloroquine first, briefly. This is the sort of the baseline data. So for the hydroxychloroquine randomization or comparison, we had 4,716 patients. We had 1,561 to hydroxychloroquine and 3,155 controls. We have a ratio of 2 to 1 for controls to cases, because we have common controls across the different groups. So we needed to have increased number of controls. Very little withdrawal of consent. Not a big proportion of patients randomized to the second stage to tocilizumab, so not really affecting the results. And we did an intention to treat analysis. So the average age is in the mid 60s, and at this stage we had not opened this trial to the hydroxychloroquine arm to children, so they're all adults. A preponderance of males, which is typical of what we see anyway in Europe in admitted patients, is that there's far more men with severe disease than women. Average days from symptom onset to randomization, 9 days. So this fits with the picture of people having a mild illness that gradually progresses and ends up in hospital. And patients had been on average 3 days in hospital before they were randomized. We had a pre-specified severity criteria. We had, at randomization, patients who did not require oxygen, patients who required oxygen, and patients who were either on ventilation or ECMO. So it's about a quarter in the first group, about 60% required oxygen, and about 20% required ECMO. And we see that typically across the different parts of the study. And so here's the baseline results. So the data monitoring committee looked at the data in response to requests from the regulator, because of the paper in the Lancet from Mera, which indicated harm from chloroquine, but actually the paper was withdrawn because the validity of the underlying data was incredibly uncertain. But that's why we unblinded the data. And the red line is hydroxychloroquine and the black line is standard of care. And you can see that there is no difference, no statistical difference in mortality in day 28 mortality. And the trial was discontinued because there was no benefit. There was no probability of showing any benefits. If anything, if you continued, you may have showed it more likely to have showed a harm, I think, as the arms seem to be diverging. So we stopped the trial and reported, as you know, that there was no benefit in patients in hospital. If you look by subgroups, this is by age, this is by gender, this is by days since symptom onset, this is the baseline severity based on requirements for oxygen or not, and this is a baseline risk based on the data, all the blinded data from the trial. And you can see the effect is very consistent across all subgroups, that this is indicating usual care is better, and this is indicating hydroxychloroquine is better, and everything is on the wrong side of the line. Most of it not statistically significant, but none of it indicating any benefit in any subgroups. So we stopped recruitment on 5th of June, and that has resulted in changes in practice. It's not a routine practice in the UK, but it has been used in other countries. And the US FDA had actually authorized hydroxychloroquine for use in patients, which they revoked that approval after we gave them a presentation on the results. So now I've gone to dexamethasone, which was the result that we reported. So the dexamethasone comparison, we had about 15% who were thought to be either unsuitable for dexamethasone or the drug was not available. And so we, with about 6,000 patients randomized to either dexamethasone or usual care. So we had 2,001 patients on dexamethasone, 4,381 on usual care. This arm of the trial reached 2,000 treatment arm, which we had sort of pre-specified as in patients to be able, if there's any a small or modest benefit in survival. Again, we did attention to treat analysis of all those patients, and a small proportion of patients also received tocilizumab, but fairly balanced across arms. So here's the baseline characteristics, and I'm showing this. It's pretty similar to the picture for hydroxychloroquine, except we did by chance have a bit of an imbalance in the age between the arms, being with the dexamethasone arm being slightly higher. Now patients were randomized, so this is an imbalance based on chance really. But what we've done is we've age adjusted some of the estimates because of that imbalance. But the age adjustment we think gives a more accurate reflection of the effect size. But we've also looked at the unadjusted effects, and it makes no difference to the conclusions. Let me get rid of that. So this shows you the patient characteristics by their level of severity at randomization. And what you can see is that the patients on mechanical ventilation are younger, average age 59, compared to 69 to the patients who didn't receive any oxygen. So what you're seeing is that there is a tendency not to ventilate the much older patients. So whilst 35% of the patients getting no oxygen were over 80, only 2% of those ventilated. So the ventilators are not being given to the very old. And you can see that there's a difference in the duration of symptoms. So the no oxygen group versus the invasive ventilation group. The invasive ventilation groups are later in disease, so about 2 weeks into disease by the time they require ventilation. In terms of comorbidities, about a quarter have diabetes, a quarter heart disease, a quarter lung disease, and this is similar across all the comparisons exactly, pretty much. And as you see here, most patients are SARS-CoV positive, about 80%, 10% we don't yet have the result, but we will get those results, and about 10% negative. Patients got what they were given. So if you look at the dexamethasone usual care, we haven't received all the data at the time I did these slides, but there's good compliance. 95% of those who were allocated to dexamethasone got it, and about 7% of those not allocated to dexamethasone were prescribed it by their doctors. So a bit of imbalance. But what that would do would actually underestimate the effect of dexamethasone rather than overestimate it. Very few patients getting any of the other treatments like lopinavir, hydroxychloroquine, or tocilizumab. Quite a number getting azithromycin as a routine antibiotic, but balanced between the arms. And here's the result. I'm sorry if it's a bit small, but you may well have seen this. So the overall effect is that dexamethasone is better than usual care. in the whole patient group. A risk reduction of about 17% in your risk of death at day 28, which is highly statistically significant. But we presented the data by severity at baseline because a test for trend showed a highly significant difference across these groups. And as you can see here, in the patients who didn't require oxygen, there is no benefit. The p-value is not significant, and actually the relative risk is on the wrong side. It's towards a hazard, with dexamethasone associated with a higher risk of death. So we've always presented the data stratified by these elements because we clearly do not want to be giving dexamethasone to mildly ill patients or to patients who don't need oxygen. That's not going to benefit them. It might even do some harm. But in the patients who need oxygen, there's a clear benefit, about a 20% reduction in the risk of death, statistically significant, and a very big benefit in patients requiring mechanical ventilation, with nearly a 35% reduction in the risk of death, and highly statistically significant. So these are the relative risks. So the absolute risk reduction in ventilated patients was from 41% risk of death to 29% risk of death, so a 10% absolute reduction in the risk of death. And in those on oxygen, a reduction in the risk of death from 25% to 21.5%, so about a 4% absolute reduction in the risk of death. And no difference in those who didn't need oxygen, 17% risk of death on dexamethasone versus 13% on usual care. So definitely would not give dexamethasone to this group. This is just the same shown in a forest plot to show you why it's presented by the 3 different severity categories, because you really do get a very significant difference amongst the groups, and they should not be presented as an overall effect. And this shows you the relative risk by the subgroups that I showed you earlier for hydroxychloroquine. So with dexamethasone, it's all on the right side, the correct side of the line, where dexamethasone is better. So by age, by gender, by day since onset, it's better in later disease, but that I think is purely a reflection of disease severity, which is correlated with time since disease onset, and a benefit in all levels of risk. So pretty consistent across all groups. Also benefit in the secondary outcomes. So this is looking at time to discharge, and there's a benefit, dexamethasone better, and the risk of progressing to invasive ventilation or death if you weren't on invasive mechanical ventilation at randomization. Again, in the no oxygen group, no benefit, but in the oxygen group, a clear benefit. So also a benefit in these secondary outcomes of time in hospital and progression to ventilation. So we stopped recruitment to dexamethasone 87 days after we started recruitment, and as John said, we announced the results on 16th of June. We're announcing these results in press releases because, as you've seen, they are in national guidelines, and it's taking 2 to 4 weeks to get data published, and we feel that the data are important enough that they should be made public, even though we may not have access to the full papers at the time we release the data. And same day we was UK made dexamethasone standard of care for patients on oxygen, and WHO are reconsidering current treatment guidelines. Now, hot off the press, lopinavir ritonavir, Kaletra, the HIV drug. This is new data from yesterday. So we closed that arm because we had a recommendation from the data monitoring committee that the chief investigator should look at the results. So we looked at the results, and we are making those public now. So we have nearly 1,600 patients randomized to lopinavir ritonavir versus 3,400, almost, no, 3,380 usual care. Similar picture, patients are in their 60s, preponderance of males, about 8 days since symptom onset. What you see is a difference in the severity of disease. So very few patients who are mechanically ventilated are getting lopinavir ritonavir, and this is because you can't give it down an NG tube. It's very hard to get the liquid formula. You can't crush the tablets, and the liquid formula is not compatible with most NG tubes. It's got alcohol in it, it dissolves them. So the results really here only apply to non-ventilated patients because you can't really give it to ventilated patients. And here's the result. I'm afraid it's another negative result, that lopinavir ritonavir is not associated with improvements in survival. The death rate at 28 days in the treatment group is 22% versus 21% in the usual care arm. So a relative risk of right in the middle, and a non-significant p-value. So the data monitoring committee asked us to stop this because there was really no point in continuing it, because it was extremely unlikely to see any benefit, and you would need a very, very large sample size, in the tens of thousands probably, to see a very small benefit. So the conclusion is no evidence of benefit in death, but also on risk of progression to mechanical ventilation or length of hospital stay in patients who are on oxygen or not on oxygen on the ward. We can't make about we can't give it to those patients, so we weren't able to do that. So unfortunately, the result is that lopinavir ritonavir does not seem to be beneficial in this patient group. So where are we now? So we've now removed 3 of the 6 drugs, 1 of which works and 2 of which don't. Negative results aren't good, but they still need to change practice so people aren't given drugs that have side effects, and we don't waste resources on treatments that aren't effective, and we also focus our attention on testing drugs that are more promising. So we've now got azithromycin, convalescent plasma, and tocilizumab in the trial, and we're going to continue for another 6 months at least, and we're looking at other drugs to put in, perhaps remdesivir to look at combination remdesivir convalescent plasma, anti-spike antibodies when they're available, and possibly anticoagulants as a different sort of treatment modality to stop the thrombotic events, but we may or may not put that in. So just a thank you to everybody, mainly to the patients and their relatives who at times of crisis agreed to be in trials, really not for their benefit, but for the benefit of future patients, and to the many doctors, nurses, research nurses, and pharmacists, and everyone else who's made this possible. So thank you very much, John. I'll pass back to you now.
No, thank you very much for that, Pete. Unfortunately, you cannot hear the resounding applause because everyone's either in the offices or their homes. I think that's pretty exciting, and really appreciate also you being able to present the results from the lopinavir also. I think that's really a good plus. Also a great example of the use of clinical trials in an epidemic or a pandemic to inform treatment policy as quickly as possible. This time you managed to hit before the curve really peaked, and I think this is what we've always been talking about over the past couple of years, just being able to get it right when to start these trials. We'll be opening up the Q&A soon, but we would have the presentation from Mainga Hamaluba, Dr. Mainga Hamaluba, based at the Kemri Wellcome Trust in Kenya, who's going to speak about the importance of clinical trials across Africa, clinical trials, be they of drugs, diagnostics, or vaccines, and how important this is, especially given the amount of genetic diversity that we have across the continent, and the fact that the epidemic is only now accelerating on the continent. And really, this is the time to collect as much clinical information, carry out trials, as many as possible, to get the right kind of information and inform treatment and other control policies as quickly as possible to reduce mortality and morbidity from COVID-19. Over to you, Mainga.
Right, thank you very much, John. I'm just going to try and share my screen now. And if you can just confirm when you can actually see it.
Yes, we can see your screen now, and
Okay.
just waiting for the full screen if you can.
Yes, I'm just trying to do that. Is that come through now?
Beautiful.
Great. Okay. I thank you very much again, John, and thank you, Peter, for those really fascinating results. And again, it's a privilege to be able to hear them in this forum. And to AAS and WHO, AFRO, and Africa CDC and the AU for the invitation today. So I'm only briefly going to talk about this so that we can get right down to the Q&A really of the recovery trial. But I think for everybody working in trials, particularly on the continent, this is a really important but also very exciting time to be conducting trials, because we do trials so that we can actually find answers that have immediate translational importance. And the type of results that Peter's sharing have relevance to the type of work we as clinicians are doing every day. So it's really quite important. And when we think about when we think about where we are in the trajectory of the pandemic, in terms of Africa, we're still very early on in it. Well, not very early on, we've still not peaked. And I think that's important for us to see that there's still an opportunity for us to try and look for effective treatments and preventions of disease, particularly in those that are highest risk. So when we can see that actually on this map, that most of Africa is now affected by COVID-19. The confirmed infections are modest when you look at compare them to the global situation. But what we can see is that the number of confirmed infections and deaths are starting to rise steeply. And I'm not demonstrating this here, but certainly the data from the Africa CDC demonstrates this. So it's a very important time to start pushing forward all our plans in terms of what trials we're doing. So when thinking about the research response to the pandemic, conducting clinical trials can be very pragmatic, and you don't need to have all these different arms of research in order to conduct them. But I think it is important to remember that actually conducting clinical trials are not straightforward. It's important to be able to pick up disease, to understand it, and also once we have interventions to know that we can actually implement them and that there's uptake when they occur. So using Kenya as an example, really, we have been working here with the Ministry of Health to try and quickly draw data from the country to try and inform how we design our clinical trials, but also how we respond to the pandemic. So thinking a little bit about modeling, so we've really trying to predict the course of the epidemic using data that's generated from Africa. A lot of the models that currently exist are really targeting the global north. And we're using data, not just the modeling data, not just to inform the trajectory of the pandemic, but also just to plan clinical trials in terms of if you're thinking of vaccine trials, for example, and efficacy of them, then you really need to know what the infection rates are and what the trajectory is over time in our setting to implement such studies. We're also looking at seroepidemiology, so really trying to get more accurate data on exposed populations in our setting, what the burden of the disease actually is, and to help us design interventional studies that suit our population. And also just to mobilize frontline workers and trying to see, understand a little bit more about immunity, how long it lasts, and who can actually be on the front line effectively based on some of those data. We are looking at clinical surveillance across hospitals, and that's really just very basic data where we're looking at admissions and deaths and trying to understand what's happening in terms of pneumonia cases. Are they increasing in relation to the pandemic? And even where resources for testing might be limited, those are the type of data that are collected every day by clinicians, so can easily be collated and help us understand what the trajectory is for moderate to severe disease within hospitals. Another very important area is the social science arm that we're looking in, and that's really trying to ensure that we understand the perceptions of public health interventions and understand the changes in behaviors and the drivers in the context of public health interventions to better evaluate our understanding of the actual disease and how the population is responding to it. We have centres of testing right across the country, and again, this is mostly a public health response, but also a research activity where we're trying to inform, trying to support the test and trace across the country. An area that we continue to work in, that everybody will probably recognize as an important area of conducting clinical trials, is engagement. And there's a lot of historical experience on the value of engagement, particularly in the context of outbreaks like Ebola, but also HIV vaccine development. And this really has to be prioritized and may slow things down. But ultimately, it's important, because if it's overlooked, then it can prevent studies starting, but also just stop them happening altogether. So these are areas that we are actively working in, and looking at stakeholders and communities, media, professional associations, regulators, and ethical committees, really trying to get buy-in and understanding, and so that even when we identify therapies that might work either in hospital as prevention therapies or vaccines, then we know what the community, the sense within the community is regarding that. And there's lots of work that's going on in Africa about trying to understand the virus and the insertions from all over the world. And there's a lot of available data out there suggesting that a lot of the insertions, over 300 at least, that I'm aware of, viruses have been sequenced, and all of these, most of them actually are coming from Europe. And a little bit about the natural history of the disease. And when we think about clinical trials, we're having to rethink the way we actually conduct them. Really thinking through a little bit, really thinking through it in the context of transmission, for example, having to be more virtual in terms of our training, thinking of factors like e-consent to make sure that we minimize face-to-face interactions and minimize transmission within a research setting, and trying to do everything remotely as far as possible, even as far as monitoring, but still trying to maintain very high quality in the type of data and process that goes on in the conduct of clinical trials. So this really is, this map on the left is just really to show you some data on the capacity we have within Africa. There's a lot of capacity to conduct clinical trials, clinical research in particular from this data, but for clinical trials as well. And the dark blue just shows you from EDCTP data, primarily around TB, malaria, and HIV research, areas that were defined as areas of clinical excellence in terms of the conduct, and then the slightly paler blue, looking at areas that very established, strong, rigorous processes in terms of the conduct of clinical research, and the very light blue, really looking at areas where there might be a little bit more support required. But I think, as Peter alluded to, a lot of trials that are conducted in the context of a pandemic really can happen in any hospital. You don't need to have very elaborate setups. You need to collect some very basic data, have very basic randomizations, and be able to collect data on outcomes. And that's what's really useful to help inform whether therapies, in particularly therapeutics in the context of sick individuals, work or not. And on the right, really, was just trying to illustrate that, you know, Africa does have a track record in terms of the type of research that we do in basic research and vaccinology, and a lot of investment has gone into all these areas. And there's a track record of our ability to be able to do this. So the capacity is there, and we are pushing on in terms of trying to find some answers that are relevant, particularly to our setting, because we have different, we basically have different systems, healthcare systems within our setup. We have a different population, and the adverse outcomes from things like vaccines and drugs do vary in our population. And we've seen this with examples like Ebola vaccines. And we see this as well with drugs such as hydroxychloroquine, of what is known about their adverse events. So we need to be able to evaluate these treatments within our context to be able to understand what will be effective here. So as we start to think about trials in our context, but also as we are already doing trials in our context, I think very much that we need to be pragmatic about it. And I think that's very clear from most trialists, that we want to conduct pragmatic trials because we understand the nature of the pandemic, and we understand that clinicians are mostly overwhelmed, and the Ministry of Health is overwhelmed in terms of trying to identify people who might be infected, asymptomatic or not, and move forward with actually treating these cases and getting clear outcome data. So I think being pragmatic is probably quite agreed across trialists. I think we also have to be adaptive. we can see from the recovery trial that the data that's coming out of the global north is really moving at a pace. And as we design clinical trials, we're quickly having to redesign them, and having an adaptive platform where that's not necessary really does help. I think some of the limitations in our setting is access to some of the drugs that are more accessible in other settings, and trying to implement trials and accessing those drugs to evaluate. So drugs on the essential medicines list, like dexamethasone, I mean, that's a fabulous outcome in terms of something that's affordable, something that's available, and can be implemented pretty much from the moment that the results are shared. So in terms of speeding up the process, I think we can't emphasize enough that the quality of review has to be the same, but it needs to be risk-based. There needs to be an approach where our ethical committees and our regulatory authorities are reviewing protocols, but reviewing them with a lens of risk, so that actually we're able to move forward in a way that fits in with the data that's coming in from the global north, but also to fit in with the pace of the pandemic, which is clearly very fast. And I won't re-emphasize engagement, but I think I've made my point that this is pretty crucial in terms of where we want to go once we actually have either treatments or vaccines that actually work. So when I looked at clinicaltrials.gov, this is just a map really just saying where all the clinical trials are happening across the continent. So globally, in terms of interventional studies, there were just over 1,000 studies going on, with about 44 in Africa, most of them in Egypt and South Africa. So I think that needs to change. I think that we need to see a little bit more going on right across the continent, and then maybe that is happening and it will be more apparent. And some of the trials that we see on clinicaltrials.gov aren't all captured here. Some of them are on PACTRA, and demonstrate some of the work that's being done, particularly around repurposed drugs, particularly around prevention, and also in therapeutics. And when we think of therapeutics, some of them are alternative medicines, and some of them are more repurposed or convalescent plasma, more phase 1 trials. So I think it would be interesting just to think through what our priorities are as we move forward. And given some of the limitations that I've described, I think really a lot of our trials have to be investigator-led, and that is the case when you look at clinicaltrials.gov. A lot of the momentum is coming from investigators on the continent, and there are some global collaborations such as the Solidarity trial that are trying to bring together sites across Africa, and across the world really. But there are a lot of investigator-led trials that are being driven in Africa, and also just establishing networks within our countries or within the continent, where we can quickly, in the context of a pandemic, start evaluating therapies similar to what's happening in the recovery trial, especially quite early on, where the cases might still be quite low. So I think that really, when we think about prevention studies, I think it's important that we also emphasize that some of the results that we get out in terms of treatment might not be very effective in terms of treating COVID-19, but actually in terms of prevention, we have good examples where even if therapies don't work for treatment, they still are quite effective for prevention. And we can think of examples like acyclovir, we can think of examples like hydroxychloroquine, so for malaria. So I think we need to remember that even if we have results in terms of treatment for studies from the recovery trial in terms of therapeutic treatment of sick participants, sick patients, then we need to think actually about prevention trials as well, because in terms of public health interventions, particularly at the very high risk, those are very important trials, and a lot of them are ongoing across the globe. I think it'll also be interesting to hear from Peter a little bit about whether it's worth optimizing some of we know that steroids work, and do we need to think a little bit about optimizing steroid therapy within our context? If that's the one thing that we actually know works at the moment, do we need to know if that's the only dose that works, and should we be evaluating other doses of steroids as well? And I think we just need to invest more and prioritize more in ongoing engagement about research and trials on the continent, so that in the context of a pandemic, when we do have an emergency, and we do want to move swiftly on with trials. There's already a lot of buy-in about clinical research and about the conduct of trials and a bigger understanding, and I think a lot still needs to be done on that because of some of the global historical harms that have been done on the basis of clinical research. And again, just emphasizing about the quality of ethical and regulatory review, and we have that within most countries, and where that doesn't exist, we have AVREF, who's always happy to support countries and review on a more on a scale within Africa, or provide support and oversight for individual countries as well. So that's pretty much summing up what I wanted to talk about, really, and just to say thanks again to everybody for the invitation to talk today. Thank you very much.
No, thank you very much for that, Mainga. I think it's absolutely brilliant, and I would like to, personally lobby John at Afro and Akona at Africa CDC. I think this is the kind of presentation that needs to be made to member states to really help push the need for clinical research, clinical trials, particularly trials that interface directly with public health and that have immediate, could have, immediate policy benefits or implications, which could impact on mortality and morbidity across the continent. Thank you so much for this, Mainga. The good thing is that this is being recorded, so you can access it at any time. We are significantly behind schedule, and I'd like to ask that we go over for about 12 minutes, extra minutes, just to be fair to all our participants, close to 300 in all, to ask the questions that they are burning to ask. So now the floodgates are open. You may pose your questions via the Q&A tab at the bottom of your Zoom interface. I know there's some questions that have come in already. I will start with one or two at the top, and then I'll prioritize those that come in after now, just to be fair to those who were waiting patiently to pose their questions. I'd like to say also to our colleagues who are from the Francophone side that we will be having another session on Friday on the same. But it will be in French. Vous pouvez poser vos questions en français aujourd'hui. Vous pouvez les mettre dans les Q&A session et on va répondre en anglais. Mais pour aujourd'hui, c'est seulement en anglais. Mais vous pouvez poser vos questions en français. So we'll go straight away to the first question, which is low-dose dexamethasone was shown to reduce mortality in severe COVID-19. What is the role of this drug, considering that the pathogenesis of severe SARS-CoV hinges on the theory of the cytokine storm, which cannot be calmed by such a low dose? Could we be dealing with some other pathogenesis which is yet to be understood or to be known? I wouldn't mention the name of the present question, but subsequently I will, because once your name is provided, I presume you don't mind your name being mentioned. Peter?
Yeah, well, I must admit we were surprised by the size of the effect of dexamethasone, but I think it just shows you that simple drugs targeting the pathogenesis at the right time in the right patients can work. Clearly it's not a drug if you're not severely ill, but if you're severely ill with COVID, which is inflammatory, it obviously is having a beneficial effect on that inflammatory process. There are other drugs more targeted at the cytokine storm, like the IL-6 inhibitor and tocilizumab. But you've got to remember that tocilizumab is about is several £100 per dose, as opposed to a pound or two or less for dexamethasone. And dexamethasone has a relative risk reduction of 30%, which is magnificent. And I think any other drugs will be hard pushed to match that. So I think it's of all the drugs in the trial, it's the one I'm most pleased about because it's the cheapest and most available. So if anything was going to work, I would have hoped it was that.
No, thank you very much for that, Peter. Another question, and this is, I'll try and summarize the question because I realized that about 2 or 3 people have asked the question around the same topic. So Chinandum Babalola and Audrey Forson and others have asked about chloroquine and hydroxychloroquine and the fact that well, from what we know about its pharmacokinetics, it works at cell entry level, which is sort of early in the disease. Asking, so more or less in the first 5 days or so is when it is theoretically expected that the drug would have the best effect in reducing the rate of replication of the virus. And so they're asking why the trial was done in patients who were otherwise quite ill and recruited into the trial in the second week when the virus is already established and replicating pretty fast. Could that explain why it was not so effective? Shouldn't our focus rather be on early stage treatment with hydroxychloroquine to really see whether it does what it is expected to do, which is to reduce the rate of replication and therefore the progression to overt or severe disease?
Yeah, I mean, so the reason we tested it was because it's in a lot of treatment guidelines. So one of the slides I showed earlier is that actually many national treatment guidelines recommend chloroquine, hydroxychloroquine, being used in China, India, Brazil. So although it may not be a good choice for hospitalized patients, it is or has been used very widely in hospitalized patients. And so I think it's important to test whether that's a sensible strategy or not. And I think we've shown that it's not. We can't say anything about whether it would work in prophylaxis or in mild outpatients. That's for other studies to answer. There's been one prophylaxis study that's reported and reported no benefit, but I haven't seen any studies in mild illness. And you're right, we can't extrapolate to a different patient population group.
No, thanks for that, Peter. I'm sure this is one question that many are itching to answer, and I'm hoping that some of the trials that are going on across Africa, and I know in Southeast Asia as well, on hydroxychloroquine will be able to answer this question as to whether it is effective, particularly at the very early stage of the disease. But a question to you, Mainga, and this has to do with someone asking, is one study enough to change practice and policy? Is there room for other studies to look at the same drugs, hydroxychloroquine, lopinavir, ritonavir? I know that there's a big trial about to start across a couple of countries in Africa looking at lopinavir, ritonavir also, and even dexamethasone. So just this whole idea of being able to replicate findings, the diversity of the genetic pool, particularly on our continent of Africa, and how that could impact on clinical trial results, and what that means for FDA's regulatory bodies that may look at findings elsewhere and be more reluctant to allow trials of the same to take place on the continent. Mainga.
Sorry, yes, John, I think you've touched on it there in the sense that normally, we want empirical studies, and you wouldn't necessarily go on just the findings of one trial in one population and one patient group. But I think in this context where we're trying to really find treatments that are effective, and where we're trying to randomize participants to patients who are sick and in hospital to treatments that might bring them potential benefits, then I think it becomes very hard to get such therapies through the regulator and get a regulatory approval, especially if you have regulators such as the MHRA or the FDA who are actually suggesting that these are not appropriate. In terms of even prevention trials, some of the prevention trials had to be halted while some of the data was being looked at in terms of safety, particularly with hydroxychloroquine. But I think that basically, it's reasonable to go ahead and evaluate some of these therapies in our population, but where there's a safety concern, then there have to be safety contingencies to make sure that there's more oversight. And some centers are more equipped to do that than others. So if you're looking at prolonged QTC in hydroxychloroquine, for example, then you may want to do that in a small hospital with more intensive monitoring, for example, and regular ECGs. But I think, to be honest, the reality is that it'll be hard to evaluate some of those therapies with our regulators in the current context.
Well, thank you very much for that, Mainga. Much appreciated. Peter, back to you. And Haruna is asking, A really important question, I think, regarding the fact that there's several other steroid options that are used in times like these, or that could be used, like hydroxychloroquine, prednisolone. What informed the choice of dexamethasone as opposed to all the others? And does this open the doors to other steroids?
Yeah, well, I think Mainga's comment about optimizing steroids is a really important one. You know, we had to choose a particular product and a duration and a dose for this trial, and we chose dexamethasone because it has very limited mineralocorticoid activity, so it's less likely to result in salt and water retention, which, you know, could be a problem in patients with impaired lung disease, impaired lungs. So that's why we chose Dex as opposed to any other steroid. We chose the dose because it's a moderate dose. High doses has been associated with harms in MERS and SARS, so we didn't want to go high dose. But we also wanted, you know, a big enough dose to have an anti-inflammatory effect. And 10 days may be too long. You know, Dex has a reasonable half-life, and you may well be able to go lower than that. There was a recent ARDS trial that used a higher dose for a shorter time. So, you know, I think it would be very reasonable to test other steroid regimes or to compare different regimes.
No, thank you very much for that, Peter. And Mainga, I'd like you to also, you know, comment on this. And John, I know you're a pediatric intensivist yourself. So although you're not speaking, I really like your take on this as well, if you don't mind. But Mainga, a number of people, I mean, Karen and Nadeem, a bunch of others, are asking questions about what could this mean in Africa, especially since we know that the use of steroids in low-income settings, especially in areas which struggle with pneumococcal infections, antenatal steroids in preterm babies sometimes have all kinds of effects. And so what are your thoughts around the use of steroids and DEXA on the continent, where we have all these other challenges which could, you know, compromise the effects and actually make it harmful? So Mainga, if you could comment on that quickly, and John, if you could also come in, that would be much appreciated.
Yeah, I think we need clinical trials in order to find answers about what treatments work and what treatments don't. I think outside, with the data we have, very much suggests that even in our context, dexamethasone when used in patients who have oxygen or are ventilated would be beneficial. I think when you start looking at different populations and thinking of pregnancy, and you start thinking about different target groups like children, then again, we've got no data in the context of COVID-19. So we are thinking about conducting clinical trials around steroid use in our population. There's no reason to suggest that the results we would see in our population would be different. But I think that really we need to conduct trials in order to get reliable data before starting treatments in other groups and other populations.
Thanks for that. Yes, John.
Did I just come in there? Yeah. So our trial was open to pregnant women and kids, but there were not enough in either group to make a conclusion. So, and in children, we actually have a mother maternal health working group and there's a document on the website about that, and they recommended prednisolone instead of dexamethasone because it has better characteristics during pregnancy. And the children arm remains open, but obviously you don't see that many children with severe COVID, so it may be very difficult to reach a sufficient sample size in children.
Thanks, Peter. John?
Yeah, okay, thank you very much for the question. And from my side too, I'll agree with Mainga and Peter, what they have said. We need to do more studies. We can't just extrapolate what has been found in COVID to other different disease conditions, and then also the age groups. We need to look at them critically and then ensure that harm is not done, and make sure these are beneficial for their subpopulation. Thank you. Over.
Thank you very much, John. I got a question from Florian Vogt, who's asking, regarding dexamethasone, did you find evidence that clinical practice regarding the decision to put patients on oxygen varied over time and or across sites? And do you think this could explain parts of the stratified results? So on a related note, how do you explain the fact that results for the non-oxygen patients were on the wrong side or on the right side? And this was this consistent across subgroups? So like gender, age, etc. within those patients. So he's asking more about whether oxygen could be the one really doing the trick, and whether variations at time of oxygen administration and all these could be a confounding factor.
Yeah, we didn't see a difference in the sort of behaviour of oxygen therapy throughout the trial. There was a concern in the UK because we had a rather astonishing number of cases that we might actually run out of oxygen and need to ration it, but we didn't have to do that. So we didn't see a change in oxygen use across the trial. But regardless of that, patients were concurrently randomised. So at any time points, patients were on oxygen and not on oxygen were randomised to dexamethasone or not to have dexamethasone. So we don't feel that would have had any effect on the result. I think it's a very good question about why there was no benefit or potentially even harm in the no oxygen group. There's a number of possibilities. One is that group was had a much larger portion of the very elderly, as you saw. About sort of 35% were over 80 in that group, and that may have had something to do with it, combined with side effects in the frail elderly of dexamethasone, in the absence of any benefit because they didn't have inflammatory lung disease. But I think from our results, we would say don't give it to anyone who's not on oxygen. But I do think there's scope for further investigation in that group. We will be doing more analysis. Yeah.
Yeah, thanks for that, Peter. We should be wrapping up soon, but there's a question in French here. Says, je me fais savoir les mécanismes d'action de la dexamethasone en cas de COVID-19. So he's just asking for just a little bit of theory around the mechanism of action of dexamethasone, like you did for the hydroxychloroquine, maybe just a little bit of that.
Yeah, I mean, basically, it's well-known anti-inflammatory properties. It's a bit of a blunderbuss, a bit of a broad anti-inflammatory. Some of the newer anti-inflammatories are very targeted, but obviously much more expensive and not available. So it really is just dampening down the inflammatory response, which I think explains why it's working in those with more severe disease and later on. It's mitigating the lung inflammation, I think. We also saw a reduced risk of the need for dialysis. So maybe having, there's also a question about whether there's a vascular inflammatory process and an inflammatory thrombosis. So it's also plausible that it might be having some beneficial impact in that area as well.
Well, thank you very much for that, Peter. We have exceeded our time considerably. But I'll just ask the last question, which is around azithromycin, and Shamsuddin is asking, I know there was an arm that involved azithromycin, if I recall. Any preliminary findings, any thoughts on that so far, especially given that azithromycin is found, quite pervasively in the standard treatment guidelines for many countries in Africa?
Yeah. No, I'm really interested to see the results of that, but currently I'm blinded to the results, so I have no idea if it's showing any benefit or not. We currently have about 850 patients who've had azithromycin and twice as many on control. So we're still quite a way off the numbers we would need, if you're talking sort of between 1,500, 2,000 patients. I think it will take us some time before we have a result on azithromycin.
Well, thank you very much for that, Peter. And unfortunately, I have to draw the curtain on this clinical update on dexamethasone and hydroxychloroquine for severe COVID-19. I'd like to say a big thank you to the co-organizers, which is ALERT, the Africa CDC under the AU, the WHO Regional Office for Africa, AFRO, and the African Academy of Sciences. We look forward to coming to you again on Friday with the French edition or version of this clinical update. I'd like to say thank you very much, and thank you for your patience as well. Sorry if we couldn't answer or pose your question, but we're hopeful that we can provide answers at a later stage. Thank you very much, and hope to see you on Friday. Have a good day.
Thank you very much. Have a good day, everyone.
Thank you. Bye, everyone.
Thank you. Bye.